All right, everyone, welcome back. Dr. Boysen, we are going to start with the subxiphoid site, arguably our most favorite. Show us how to do it.
Absolutely. So let's do into more detail on what we can answer at that subxiphoid site and how we actually locate that site. So the easiest thing to do on this is to make sure you tuck the probe right into the actual V formed where the ribs come together and you see that subxiphoid process. So a lot of people, when they do the subxiphoid, they're a little bit caudal to it. You need to tuck the probe as far cranial into that V as you can. So trace those ribs down, find that spot where you can palpate the subxiphoid site, and then when you've got that site located, again, we separate the fur, we apply alcohol once you can see the skin, and then what we're going to do is we're going to place the probe exactly in that subxiphoid location. We're going to start, in this case, in long axis, again with the marker towards the head.
That's a beautiful image, Dr. Boysen. So let's go ahead and answer those binary questions. First binary question, which goes back to the original FAST. Is there abdominal effusion at this site, yes or no? So Dr. Boysen is going to fan that probe really widely in long axis, and then we're going to do the same thing in short axis to increase our chances of potentially ruling in or ruling out fluid there, Dr. Boysen.
All right, so we've done it in long. I'm going to flip it into short axis, and I can plan all the way cranial and all the way caudal, just to make sure I don't have any free fluid when I'm scanning that site. So now I'm back in long axis again.
Yeah, and very important to change the depth here so that you have the entire diaphragm and liver, the diaphragm going around the entire liver there. So Dr. Boysen, I saw the gallbladder there, so why don't we go ahead and answer that question there. Is there a gallbladder wall halo sign, yes or no? So we're looking for the thin wall of the gallbladder, which is normal, versus that dematous looking gallbladder.
Absolutely, and when we look for that gallbladder, it's just to the right of midline, so you can see that when I've got my probe here straight in on midline at about a 45-degree angle is how we want to look for that gallbladder and assess this subxiphoid site initially for fluid and assess the gallbladder wall. The gallbladder sits just to the right of midline, so he's in left lateral, which means the gallbladder is going to be a little off the table, so we're just going to fan the probe to her right, and there you can see we pick up that gallbladder really nicely. And I look at that, Dr. Schlub, I see very thin wall. I can see that it's just barely visible. It's a white line that we can see there.
Yep.
But it's definitely not thickened, and I definitely don't have a halo sign. So that's the gallbladder we're going to look for there. I'll fan all the way off one side, fan all off the other side, make sure that disappears, and we'll come back and do the short axis of that at the end as well.
Very much, Dr. Boysen, and since we're here, I see a beautiful caudal vena cava. We're going to ask a question here. Can we safely give this patient IV fluid bolus, yes or no, by looking at that caudal vena cava and look at that change in diameter, Dr. Boysen, for respiration?
Absolutely. So I can see that here in the far field. It's at about the 10 centimeter mark. You can see that we've got the two parallel lines, the near wall and the far wall of the vena cava, and it does have a couple of things we look for. As you mentioned, Dr. Schlub, we can see the bounce here, so the cardiac pulse. That is a normal finding. We lose that when they get volume overloaded. We can also see that the diameter, the distance between the walls of the vena cava, gets narrower on inspiration versus expiration, and we expect to see at least a 25% change in the diameter of that vena cava at this location. And that's basically used for us to determine, can we give this patient a fluid bolus? Is our patient fluid responsive? Yes or no.
Yep. The other thing, Dr. Boysen, we're getting a good look inside the thorax from this site here, Dr. Boysen, and we see a perfect mirror image. Mirror image meaning that we have air on the other side, Dr. Boysen, and we don't see any pleural effusion, for instance.
Absolutely. So we do look for pleural effusion at this site as well. We extend the depth beyond the diaphragm as we've done here, and you can see that beautiful mirror image artifact. We only see that when there's air on the other side of the diaphragm. So at this particular location, in this particular plane, I can say confidence there is no pleural effusion on the far side of the diaphragm in the distal image, because we see that lovely mirror image artifact. We also see a B-line here, Dr. Schlub.
I'm sorry, you mean a lightsaber, Dr. Boysen?
So we see that vertical white line that's coming off the diaphragm. We do look for lung pathology, Dr. Schlub. They look like rays of sunshine coming down from the heavens. If you prefer the lightsaber, you can use that as well. But you can see we got this vertical white line. We can see lung pathology. In this case, seeing 1 to 3 B lines at this location coming off the diaphragm would be normal. But if we have increased numbers, then that is a concern as well.
100% epic Jedi fight right there, Dr. Boysen. I think I saw the heart come in there for Dr. Boysen. That's another great thing about this subxiphoid site. We can determine really quickly, do we have pericardial effusion, yes or no? Arguably, better and faster than looking at transthoracically.
Absolutely. So coming in, I'm actually come back more to straight midline, to a little bit left of midline. Again, the gallbladder's to the right of midline, so I'm here on the gallbladder. I'll just fan down towards the left side of my patient, in this case towards the tabletop, based on how Penny's positioned. And you can see that cardiac blend. So we see that left ventricular free wall blending into and becoming one with the diaphragm and the liver, so we can see that contraction there. In this image here, I can actually see the left ventricle in its entirety. This is a really nice view that we have with the Clarius at this site here. But all I really need to see to rule out pericardial effusion, Dr. Schlub, is that cardiac blend where that left ventricular free wall is continuous and blends with the soft tissue of the diaphragm and the liver. Ruled out pericardial effusion very quickly. Nicely done, Dr. Schlub.
Okay, so some other questions that we can ask here, Dr. Boysen. Let's go ahead and rock that probe and look at the stomach. And we have the stomach here, and we can see if there is gastric contractility here, yes or no.
All right, so and what we did then is when we're actually looking at the subxiphoid to assess the heart, the gallbladder, and the liver, you can see I'm at about a 45-degree angle here. When I want to assess the stomach, I know it's caudal to the liver. So I'm just going to unrock that probe, come in more perpendicular, and you can see we drop right onto the stomach of Penny here. Now, Penny has a pretty full stomach. That's a large stomach there. But if I hold this here long enough, right there, look at that contraction.
Ooh.
So we can see that GI motility, a wave or a contraction of the stomach, and that tells us that in this case we wouldn't be having, for example, generalized ileus. So generalized ileus is something that we will look for in our postoperative patients, and seeing that contraction in the stomach rules out a generalized postoperative ileus, for example. Doesn't assess all sites of the intestine for ileus in all locations, but it's a nice spot for us to look for it at the stomach.
100%, Dr. Boysen. So if we see you doing breakdancing in that stomach, we rule out generalized ileus. Now, one thing, Dr. Boysen, since we're at the heart, something a little new, Dr. Boysen, we can look for contraction during CPR.
Absolutely. So this is another site when you're doing active CPR. If our patient was most comfortable in lateral, and that's the position that we are doing our CPR, I can actually put the probe on at the subxiphoid. I can see the heart here at this subxiphoid as you see now, and we can actually judge the degree of compression during active CPR. And when we switch compressors at that 2-minute mark, we have about a 5-second, 7-second window. I can assess that free wall of the heart right there and say I have ventricular fibrillation or I have no cardiac activity versus I have cardiac activity. So again, one more thing we can look for at that subxiphoid site that's pretty new, but we can assess cardiac activity in our 5-point APOCUS exam at this subxiphoid location.
I love it, Dr. Boysen, and let's not forget we do all of this in short axis as well. And here we have a big smiley face with the liver on top there. That's how we know we have the entire image, and we can ask the same question. Dr. Boysen, I love it. And that was the subxiphoid site of the abdominal POCUS. Mwah!